everyone. We are in our CCO Club webinar number 93, getting awfully close to 100. And we have a case study tonight. I love risk adjustment, as you know, and we have a skin ulcer case study. We're going to look at it from the perspective of risk adjustment. That means we are going to look at all the diagnoses that show up for this patient, but it's actually a patient that has a skin ulcer. Therefore, we're going to look at that, and we're going to get practice abstracting, but at the end, I want to see if you notice the missed opportunities that we're going to go over. And I suggest that you have a pencil and paper and you make notes as we go along. This is kind of a new format on how I'm going to present this, and I'd appreciate your feedback. So let us know in the chat if you're on here live with us. Again, don't forget to give us a thumbs up, subscribe, and let us know if at the end this works for you. So practice abstracting, talking about the disease process, looking at the format of the document itself. Not always easy to put a case study, especially a robust one, in a slide deck. Let's get started. Plus we have animation in that, which I'm so excited. We're going to look at a patient that's all been redacted, everything's been changed, so disregard any dates that you see. I went and put X's on most of them because they're not going to be pertinent for the most part. However, in risk adjustment, the first thing you're going to do is verify that you have the right patient, that it's the right date of birth, and you have to have a date of service or you cannot abstract from that document, as well as a signature. Now, this one is not electronically signed because we just took that off. That wasn't something that we were going to look at. And this is pretty close as to what you're going to see when you look at regular documentation. Thanks, guys, for telling us where you're coming in from. That's always fun. I like you doing that. Now, we see that we have a Mr. Green here, and why is he coming in to see the provider for medication refill? They don't like, just so you know, they don't like for you to providers to put chief complaint refill of medications. That's not actually a very good chief complaint. As an educator for providers, we have them steer away from that, using verbiage instead as to reasons why the medication, why he takes the medication. That's why, chief complaint, and even like follow-up, right? So what are the reasons he's being seen? And because you got to review the whole disease just to refill the medication. Usually, you will always get the vital signs and everything lumped together. But again, we're just going to scan through this quickly, and then I'm going to break it down a little bit more. I want to tell you about the format of an encounter, how it looks. So sometimes you get all the vital signs right there by the name. Sometimes you get it right there above the review of systems. But always pay attention to the BMI. Very pertinent, because if you have a patient that's overweight, that BMI can be meat, right? Now, Sarah made a good point. We use medication reevaluation. That is an excellent, I'm going to remember that. Yes, that is a very good way to state it, because that shows medical decision making, not refill or RX refill. Not a good one. All right, so we're not going to talk more about this slide, but I do want to say, is there anything that pops for you as you just eyeball this really quickly? For me, it's right here, insulin syringe. So I automatically know I got a diabetic on my hands, right? You don't give insulin syringes to somebody that's not a diabetic. And then I see inject right here. So again, medications reviewed. Sometimes you'll see dates. That's always good to have that. Now disregard this. I should have X'd that. Oh, I did. I put 20 and took off the rest of that. You would never see just 2 characters in a date. You're always going to have 4 characters in a date. Problem list, kind of give that the old hairy eyeball, coder eyeball, I guess is a better way to see it. Ooh, look, amputation. And then we're going to keep going because we're going to look at this more in depth. We've got the HPI, we've got a review assessment and the assessment and plan. Again, for our club members, you get a copy of this slide deck as well as the recording and the access to conversations ongoing regarding this. So again, we'll look at this more in depth. Now let's start uh, at the beginning. We have our patient, we verified the date and that the date of service, all that stuff is accurate. We have our allergies, which sometimes can help you and other times not. Now we're actually going to look at the meds, and we see aspirin. That's probably a cardiac issue, right? Off the top of my head, or what off the top of your head, what's the first thing that pops when you see aspirin? What is a disease process that is getting medication? Of course, go ahead and put it in the chat. Insulin. So we know the patient's on insulin because of the syringes. And sure enough, we see two types of insulin. Uh, the once you have so that could be a type 1 or a type 2 diabetic. Furosemide, well, he's got fluid buildup or we wouldn't be getting a water pill. Let's see, and we got Lancet, Simvastatin, that we know what Simvastatin's for. Again, pop up in the chat when you see medications. Tiffany says CAD and MI, absolutely, old MI. You're going to see those. Just pop in the chat just what you think at just looking at that medication list. CVA, past CVA, yes. Uh-huh. Very good, very good. Okay, I'm going to go ahead and look now at the problem list. We have amputated foot, ding, ding, ding. Things to keep in mind when you're doing risk adjustment is every year, January 1st, even though it sounds ludicrous, if the patient, whatever diagnoses have been captured the previous year, go by the wayside. Why? It has to be reevaluated every year, or you don't get to capture it. So that amputated foot mysteriously grows back every January 1st. We have, let's see, peripheral artery occlusive disease. So again, that's PAD. Diabetic skin ulcer. There we go. We knew we were doing some type of skin ulcer. Yes, several of you guys said DM for before, but now you are looking at the problem list and you're saying, hey, we have more than one type of diabetic complication. So that's interesting. That means we get to capture if we have meat, because just because they're on there does not mean we have meat to be able to capture an HCC. That's what we're going to look at. So we have CKD, it's staged there on the problem list, but we got to have more. We have type 1 diabetes. So this is not going to be an E11. These are E10 codes, type 1 diabetic. We have retinopathy. We have a depression. We have renal atherosclerosis, neuropathy, edema, which comes with having all that other stuff, and hypercholesterolemia. All right. Ooh, he was adopted, and history unknown, other history. Social history kind of doesn't matter for us for the most part. Surgical history, this does. So we have an amputation, 5 toes, left foot. And then we have angioplasty, left lower extremity, colonoscopy is negative, and retinal surgery previously. Okay, that verifies that's the meat for the amputation on the foot. Very good. That's covered. The past medical history, CAD, diabetes, cholesterol, prostate cancer, hypertension. Who knows what AAA stands for? PAD, foot ulcers, and vitamin D deficiency. Vitamin D deficiency is getting much more prevalent now than it used to be that we're seeing. Anybody know what AAA stands for? It's for an aneurysm, right? Aortic aneurysm. Okay, let's look at the HPI real quick. We have patient is there for their 6-month checkup. He's feeling depressed about his amputation and his inability to go out and do things he used to do. This is very common. And now there's new codes, some new Z codes that don't risk adjust, but your providers can use to explain some of these other situations that are happening in their life. Glucose levels are higher than what is healthy because he fears hypoglycemic episodes that he experiences when in thought control. And as a result of the Lupron injections, he currently has a diabetic foot ulcer on his left heel, for which he sees his podiatrist twice monthly. All right, so that gave us a lot of information. Does anybody see anything in the HPI that jumps out at them? Now, make sure you write this down in your notebook as you follow along, because we'll cover these. I want to see if you catch them at the same point as we're reviewing them, or if I'm going to bring them to your attention at the end. So we're now doing the exam. Well nourished, good judgment, normal mood, blah, blah, blah. Now, it says normal mood, although it says he was feeling depressed, right? Is that contradictory? Lungs okay, cardiovascular. Oh, that's a very common statement right there. Everything, it says normal S1 and S2, no murmurs, rubs, or gallops, and RRR. Tell me what RRR stands for. You get a gold star if you can come up with what RRR, I almost said it. Musculoskeletal, no cyanosis, edema, or clubbing, but we noticed that he had edema in the past, so we'll see if that's pertinent. Followed by the podiatrist for his angiopathy, for his foot ulcer and his diabetes. Amputation of all 5 left toes in healing. It is healing well. Ulcer noted on left heel. So there's not much. Yes, respiratory rate. Yeah, rest rate. And then very good, very good. Regular rate and rhythm. That's, yeah. And so again, we have a recent amputation. It's healing well on that foot, but the heel has developed an ulcer. That's not good. So that's the same. It's left and left, right? Same one. So the assessment and plan, you got a type 1 diabetic. He needs to be under tighter control for his A1C, and they're going to do a comprehensive metabolic panel, very common. MDD, major depressive disorder. So again, we have the physical exam that said that he had normal mood and affect. That's kind of versus in the HPI where it says he's feeling depressed. So this would be patient recurrent major depressive disorder that dates back to his teens, and he's had several hospitalizations. That's different than I just don't feel, I'm feeling a new depression due to my amputation. He weaned himself off his antidepressant 2 years ago, and he discussed with him his new health status and its impact on his MDD, but he refuses to go back on meds. Hypertension, well controlled, but his podiatrist records show very stable numbers. Okay, a bit elevated today, but he's doing good. The foot ulcer and amputation. So the amputation side is looking good because there's codes for any complications to the amputation site. Notice they took his toes, so kind of mid-foot they took off, but he still has part of his foot. So it's not really a full foot amputation, but that's what it is looking at. Yes, and Nancy brings up a point. He might be staple on the date of service. Could be. You're absolutely right. That is a good point to make why it says HPI is that he has been depressed, but today he's in good spirits. And but so if there was a complication and the wound wasn't healing where they recently did the amputation, that's the different code. But the foot ulcer at the heel is different than having that there where the amputation occurred, even though it's really close. Then hypercholesterolemia, he is going to do a lipid panel, and the vitamin D deficiency, they've obviously got him on supplements. All right, so I hope you're making notes there. Hi from Frisco. I've got friends in Frisco. Now we're going to actually pull it apart. We've kind of scanned through it. Went through it quickly. Now let's put everything together. First, we're going to look at the diagnosis codes that the provider picked. And this is very common for the provider do it versus a coder. And they don't usually get to the highest specificity. And then we're going to come back and look at it, what we could or could not abstract as for risk adjustment. All right, diagnosis codes, starting with what's the chief complaint? Already commented we didn't like that, right? So I put that's in red. E10.51 because we have type 1 diabetes, that's the E10, and then we have diabetic peripheral angiopathy without gangrene. Whenever you have any type of diabetic skin problem, it's going to always ask you with or without gangrene. If it's got gangrene, then you're in for an amputation for that patient. Then we have E10.621 because we have diabetes with a foot ulcer, right? Now, you say, well, doesn't that get all caught up in the peripheral angiopathy? No, that's actually two different codes. Then we have to identify the foot ulcer with an L code. L97.429 is appropriate. That's a very long code, but it's because we have laterality and specificity of the foot itself. So it uses every character that we're going to need. So we have a non-pressure ulcer. That's pertinent. It's not a pressure ulcer. That is on the left heel and midfoot with unspecified severity. Now, that doesn't give us much. We don't want to see that, but it could be there's a need for that if he hasn't got in and debrided it or done much. And obviously, this isn't why he's seeing the provider today per se. It's being followed by the podiatrist, and he sees him twice a month. So if he goes back and we look at the podiatry report, we would be able to achieve a higher specificity as far as the severity, because you could use whatever the podiatrist used in his notes. And sometimes, though, they're not in the same facility. So like if you use Epic, they'll have a media tab and you'll be able to see all of the documentation from the other providers, even if they are not on site or part of your system, like a big system. So again, unspecified severity, we probably could get that severity if we dug around and looked. And as a risk adjustment coder, you would have that if you're working for a provider or a facility. But if you're doing risk adjustment for an MA plan, you're not going to have access to that necessarily. You're only going to have a year's worth of documentation that's in front of you. Now, the fact that they're seeing a podiatrist twice a month, you're going to have some podiatry documentation. But as an MA plan risk adjustment coder, they're giving you everything that was in that patient's file. So again, you could search around and dig around and maybe find that severity. Then a coding tip. Now, you're not going to use E10.9 for your type 1 diabetic or type 2 E11.9 if there is no if there is diabetic complications. Why? Because that is opposite. So E10.9 says I'm a type 1 diabetic with no complications. But if you are a E10.51 and a 0.621, you have complications. You can't use those codes together. However, you can use as many diabetic codes as it is needed to describe your diabetic. And I've seen them use every available code from, here we have a skin ulcer, we have angiopathy, we can have ophthalmic, which is a 3, I think, 2, I think is neural, we can have renal, we can use every single one. And the reason why it's important also for these to all be captured is now in risk adjustment, when you have a patient and you're compiling their RAF score, if they have 4 or more chronic conditions, and all those 2 diabetic codes that are listed right there would be 2, then there's a bump in that RAF score. They get a bonus because obviously it's more complex to take care of that patient. And if you're not capturing all of the chronic conditions, then you're not going to have enough money set aside next year to take care of that patient. So it's really, really important important to capture it at the highest specificity and everything that you have meat for. All right. Now, what's the meat we have for those three diagnoses in the physical exam? It tells we're going to the podiatrist and identify the ulcer. The medication, they're on aspirin and let's see, clopidogrel and humulin. So that's all stating that we have one diabetic is the humulin, the aspirin and the clopidogrel is for the heart disease. The problem list, we saw the atherosclerosis of native arteries and its extremities. We have a type 1 diabetic with a skin ulcer listed in the problem list. So we have plenty of meat to be able to verify those. The HPI even states we have a current diabetic ulcer and he's seeing the podiatrist twice. Now, don't think that it's not like when you do E&M when you had to say, oh, we can't split this. We use this for leveling on this component and we can't use it for another. No, the fact that he goes to a podiatrist, it's stated you can use that for as many things as needed. It isn't a one-on-one type thing. All right, and surgical history, we have an angioplasty, left lower extremity in the past. We also have the past medical history, the patient has PAD or had PAD. And in the assessment, we're doing an A1C, we're doing a metabolic panel, and that the ulcer is being covered by the podiatrist. All right, we're still going. Now we have the MDD, the major depressive disorder. It's recurrent and it's unspecified. Now, probably unspecified is not what we want. We can really spell out what the MDD is. We can. They want to know if it's mild, moderate, or severe, and they also is built in the let's see, there's like two or three things. We want to identify the type, which we have recurrent, not single, which is the first time they're diagnosed with it. And then we also have let's see, the type, there's three things. The other two things escape me. I was just talking about them today. So, oh, and in remission or not, that's what it is. But we don't have that. So again, well, there you go. I got a note here. So we have MDD F2 or F32 would be that first episode, and then there is a new code that dropped for depression F32A, but we need episode severity and status. That's the three things. It's a good thing I put that note in there, or I might not have remembered to tell you. Aren't these little animations fun? So what's our meat? HPI. He's depressed about the amputation. Inability to be able to do what he was doing before. Assessment and plan. Hey, we have recurrent MDD, and it goes all the way back to his teens. He's even been hospitalized. He's on an antidepressant in the past, but he doesn't want to take it again. Now, this does not mean non-compliance because it hasn't been prescribed to him. So don't get confused and try to add that in it. And yes, Mary, they always ask if it's a psychotic, if certain characters will lead you on MDD for the psychotic component, but again, all of ours is unspecified. So, but yeah, that is part of the status. And then the problem is we have depressive disorder. Now let's move on to essential hypertension, I10. Our meat is medications. We got several medications that can be linked. Furosemide, which is a water pill. It's just generic Lasix. Losartan, that has the HCTZ in it, hydrochlorothiazide. I always love saying that word. And metoprolol extended release. Those are all medications that will can be used for hypertension. The problem list, essential hypertension. The PMH, hypertension, assessment and plan, well controlled. It's a little bit elevated today, but the doctor that is seeing him for his feet said it's been pretty good. Then we have E78.00, which is pure hypercholesterolemia. Don't get into the trap of just picking that generic high cholesterol. There's more than one type. E78.00 is one. So the meat, medication, Simvastatin, anything that says statin at the end is going to be for cholesterol. Then we have in the PMH, we have elevated cholesterol, an assessment of plan. Hey, we're going to order a lipid panel. All of those give you that magic golden thread to go from one to the other. Vitamin D deficiency unspecified, then our meat for that is right there on the problem list, and the PMH assessment and plan. He's taken his vitamins, so we're good. Then we have Z89.412, very important. These get overlooked, and we have to make sure that we have it captured. Acquired absence of left great toe. And then acquired absence of other left toes, Z89.422. Now, when you build out these codes, Z89 is your acquired absence that are going to relate. Then you have to say, where is it? The 4 says, it's going to be a foot area or a toe. And then laterality is in the last character, the 2, and the 1 and the 2. Second to last character identifies what it is, the part of the foot. Now, note, when you have a lower extremity amputation based on the PMH, or if you have a problem list, sometimes internal policies will say, hey, you cannot capture off a problem list. But when it's an amputation, a lot of times they say, go ahead, right? And you will frequently find amputations listed up next to the BMI and the vital signs. So always give that the old coder's eyeball. And can a patient have psychic pain if amputated body parts? Absolutely. There's a code for that. It's actually called phantom pain, and it does not risk adjust. But yes, there is phantom pain codes. Problem list, amputated foot. Surgical history, okay. HPI, depressed about the amputation. Physical exam, recent amputation of 5 left toes is healing well. Plenty of meat. Now, what about Z87.891, personal history of nicotine dependence? This doesn't risk adjust, but of course, these are the things that are coded by the provider or the coder for the event for that day, right? This is not the codes that were captured by the risk adjustment coder. Meat for that, though, social history, retired former smoker. Well, I am interested to see now what some of you thought before I jump into this, and we're going to do this animated. Anything that you saw that really jumped out at you? Aziz says we need to ignore the contradictions in PE. Well, sometimes you can and sometimes you don't. As a risk adjustment coder, if there is no other link, you're kind of up the river, right, without a paddle. But as a pro fee coder and an auditor, yeah, you don't want to see those contradictions. But if you can find meat in risk adjustment someplace, it's acceptable to grab it. The main things that we see for amputations or even with skin ulcers is going to be things like good bilateral pedal pulses. If you were to see that on this fella, that's not going to happen. But however, he does have part of his foot. So if it's just the toes that are amputated and he has midfoot, you could get a pedal pulse there, right? Because the pedal pulse is at the top of the foot. That is, but when you have BKAs and the like, that's kind of frustrating when you see that, because they're just copying and pasting that information, and that's never a good thing. Good point, as is. Jane says, I think it codes better if current smoking F17 instead of Z72. But didn't it say that he was a past smoker? I'm pretty sure that he is a past smoker, so we wouldn't use the F17 code for current. And then, let's see, reading a medical prescription or phrase, but it can mean something else that has a diagnosis code. Absolutely correct. That is a good point. past smoker Z87. You guys can go look at that. Now, that doesn't risk adjust. So again, only chronic conditions that are current risk adjust, but we can't turn off as coders. We can't turn off that prophy and that regular coding that we look at, right? And but for this particular scenario, and we're looking at the prophy, yes, you're right. You have to be able to know, is it, don't get confused, past nicotine addiction, current smoker, stuff like that. So would F17 risk adjust? No, I don't believe it does. No, smoking does not risk adjust. I'll double check it for us, but no. Anybody got their manuals out? They can look it up real quick. I don't think I have my encoder up in the background, but I have fiber optic now. Woohoo, guys! I can turn it on in an instant. Mm. Okay, let's go through the missed opportunities. This is the fun part. Now, at this point, we're looking at it from a risk adjustment standpoint. We are risk adjustment coders or auditors, provider educators, whatever, but we're not looking at pro fee anymore. We're looking at it from, we saw what the coder and the provider coded. And again, providers are having to code now and pick codes, and they don't always know the right code. They're not trained to do this. Very first thing is to note that you are not the backup. Many of these diagnoses in this patient's record were not addressed during this encounter. So you're going to see documentation errors affecting risk adjustment scores as we move forward, because that's not why the patient was seen that day, right? The codes that you see are, why was that patient seen that day? Now, as a risk adjustment coder, you're looking at all the chronic conditions, and we want to find meat. And hopefully we can do that with the medications and so on. So let's break this out. Just note that. First thing, prostate cancer. Did anybody get prostate cancer? Anything on prostate cancer? Was that on your list at all? And you're probably going to say, yeah, wasn't that on the history of prostate cancer? But what do we know about provider documentations and the term history? It's just a list. The patient has a history of an amputation, hypertension, hypercholesterolemia, history of type 1 diabetes. You don't get rid of type 1 diabetes, right? So you cannot go by what the provider says is a history of. We have to educate them on what that means. And Jane said, oh, okay, they need a book report on ICD per medical specialties. These facts might help doctors. And that's why so many coders are hired as provider educators, especially in risk adjustment, because they say, oh, well, you've got Epic now. Epic is built in. You just put in a few words like depression, and it'll fill in all the blanks, and you'll be able to get to the highest specificity, but it doesn't work. Let's see. Mary says no, but the Lupron makes it current. Ding, ding, ding. Jane Spitfire, you get the gold star for the evening. Good catch. Now, what does this tell you about your ability as a risk adjustment coder to know medications and the disease process? If you didn't know that Lupron is a medication that men with prostate cancer are put on, then you would not think to even question that statement of history of prostate cancer. Very good. And note here, we can't capture it probably, because based on risk adjustment rules from CMS, this is straight from them, we can't code from the PMH. So we're screwed. So when that patient has a problem next year with his prostate and has to have surgery, or there's a major complication, which it's going to happen, then there's no money set aside for that patient to have that care. And prostate cancer is, what is that, C61 or 31 or 41? I can't remember. I think it's C61. I used to, I get them confused when I'm on a roll. That carries a significant RAF score for our patient. It's cancer. And then if it metastasizes someplace and gives that patient a secondary cancer, that RAF score goes through the roof. Okay, thanks, Jane, for saying that C61 is right. I thought that was right, C61, but every once in a while my brain goes wonky. Okay, prostate cancer, missed opportunity, and could have easily been noted by the provider somewhere to just show that it's active. But since it was only in the PMH, we can't capture it. CKD. Now we saw that. And with CKD, that affects more than one disease process. So we saw that the patient has CKD in the problem list, right? And we have the staging. Sometimes we don't get the staging. It does risk adjust. But guess what? It also changes the hypertension score. When you have CKD and you have hypertension, what do we know? We change the code, right? We are no longer an we are no longer a N18.4 alone. We are an N18.4 and an I12 for CKD and hypertension. Now there's one other character on there, but I can't remember if it's a 1 or a 2. 4. Let's see, CKD4, I think, is the 2. Or it's an O12. Anyway, that last character. Oh, there we go. Swag official says I12.0. Very good. Because if it's like 1 through 4 is a 0.0, and then 5 through end-stage renal disease would be a 0.1, or and then I think 9 would be unspecified. Again, I try to remember those, but sometimes I can't. Mary said, well, E11.22. Yeah, we have CKD and diabetes, but if the provider doesn't link it, then we can't. However, no, I about told you wrong. No, absolutely. We would be able to capture the diabetic code with renal manifestations, which was CKD, which would be, and they're type 1 diabetic. So instead of E11.22, Mary, it would be an E10.22. Very good, Mary. Great. All right. So now we know that when we don't capture one, then it affects probably more than one code. So we have a DM code as well as a hypertension code. The abdominal aortic aneurysm, the AAA, it's on the PMH, but guess what? No evidence that it was addressed anywhere, and you can't use aspirin for an aortic aneurysm as a link. Some might push it and say, well, yeah, you can, because they put you on anticoagulants. However, no, that probably would say, they would probably say no. So again, aortic aneurysm, that is another high HCC, which would affect the RAS score. Mary says, I took your class 2 years ago. Ha, there you go, Mary. That's why she's so smart. Thank you, Mary, for saying that. All right, so this is kind of old stuff to you, right? Good review. Now let's move on. Diabetic retinopathy, neuropathy, and nephropathy. Okay, so again, the CKD, that brings out the E10.22. But let's see, we got all 3 complications for, and they only captured 2, didn't they? 2 diabetic codes. And then my big screen's over here. That's why I keep referring back. And this screen, it's too small, so I can't see it very good. So excuse me while I turn my head. So we've got capturing 1 diabetic HCC is not equivalent to capturing all that are available. And we want to capture every single one. Every single one of those is a component of the RAF score. And if we don't have an accurate RAF score, meaning capturing all of the HCCs, then Medicare doesn't know to put that money aside for that patient. Ultimately, if that happens again and again and again, we're losing money for the care of our patients. They're cutting them short, and eventually they'll just tell that provider, you know what, it's not cost effective for this relationship to go on. You can no longer take Medicare patients. They don't pull the plug right away, but you don't want to have recurrent again and again missed opportunities. We are the keepers of the patient's RAF scores, especially their PCPs, and the CMS and Medicare relies on the primary and us as risk adjustment coders to keep it to the highest specificity. Otherwise, we can't show the complexity and the severity of the patient population that we're dealing with. So again, coding from a flawed problem list is always risky. So be very careful with that. We have to always have that magic line all the time. Let's see. Jane says, years ago, they would tell medical coders, just code, not need to be aware funds tied with the details in the illness. Well, in the past, it didn't really make a difference because it was all on the CPT code and the ICD code. You could throw one in to show, medical decision making and that linked and everything. However, that pendulum has swung a long time ago, and now medical decision making, medical necessity is reliant on those ICD codes. They tell the story. And eventually, honestly, it's going to switch to where the ICD code, well, it already is. Risk adjustment pays on the ICD code, not the CPT code. So there you go. Pro fee pays off on the CPT code. But how long before everything risk adjusts, which it already does, because Medicaid is HHS, HCCs, and other insurances that are federally funded, thus most of them. Again, it plays a part. Now we're not done. Oh, wait, maybe we are done. I think that's all of them. Yep, sure enough. Any questions now? Let me go back real quick before we end. Any questions off topic? Does social determinations and health risk adjust? They do not. They do not. Or will they increase the HCC of chronic conditions? But you can use them as a magic golden thread for meat, right? Now, social determination codes, those Z codes, I kind of alluded to those in the beginning. Patient not having enough money to get prescriptions, patients homeless. There's even ones for patients living out of their car, had a loss of a job. All of that stuff is being tracked, or there's codes for it. Why? Because we're tracking it. We code for statistical purposes. It happens to be a convenient way to get paid, right? Now, you're probably tired of me saying that, but it is the truth. That's the facts. Let's see. Jane C. Jane said, I read a book once called Every Patient Has a Story. Really good book from an intern and interns and med doctors. You know what? That sounds really great. We should find out about that book. If you can find that, Jane, and maybe on Amazon, you can come back and put the link for it in the chat later. Because again, this chat is going to go on. However, if you're in the CCO club, you can just jump out there and we'll find that book. Thanks for saying that. That sounds like a book I would really enjoy. Let's see. Jane said, yeah, block that Z53 through Z55. Those are relatively new codes. I encourage you to look at those, and if you're doing any type of provider education, to make sure that your providers are aware of them. They're not a MIPS or quality measures, but it's going to happen because, again, they're new. Let's see. Sarah says, what if a patient had fix applied to heal? Would you just use pressure diagnosis or add other supporting? I'm not sure, Sarah. I mean, just the fact that they applied it for healing to that, yeah, that would be meat. That would be meat. Let's see. Oh, look, the book link. Jesus already found it, Jane. It's in the link there on Amazon. Thank you. And Nancy says, I passed my CRC 4 years ago with our course. Thank you for saying that. And okay. Oh, I've checked them out, and Doc used them as first diagnosis. Okay. I'll look up at that and see. Oh, you were talking about the Z codes. Yes. All right. Drives me crazy when they use those Z codes, then need to tell me why homeless or non-compliant. And that does play. But those codes are to help promote, well, statistically, we're going to capture which it's part of the patient's needs. But as they capture that, then we'll go towards the need for universal health care, I'm sure, or supplementing the health care in some way. I'm sure that's the eventual. But they are really good codes, and we need to tell why the patient isn't getting better or why they're not taking their medication, etc. I think that not taking the medication because they can't afford it is a really good code to capture. All right, guys. Yeah, more with Medicaid. Actually, yes, more with Medicaid. And there's some grants and stuff out there for people that can't afford medications. So that could show a component to get the medical necessity for those type of things. Guys, don't forget that if you're not already a part of our CCO club, that's really easy to find. Just go to the cco.us/club. I really, really want you to take advantage of all the opportunities that are in the CCO club. So just to recap, you're going to be able to get all of the slide deck for you to look at whenever you need to. You're going to get the recording. You're going to get the additional conversations that happen. But don't forget to thumbs us up. That helps us, and it lets YouTube know that we're giving quality information. So if somebody wants to do a search on risk adjustment and pressure ulcers and abstracting things like that, it'll pop for them. So we appreciate your help. All right, guys. If you like this format, let us know. We've got more opportunities with risk adjustment, and I look forward to sharing with you again. You're welcome for the great information. Oh, I want to give a special shout out real quick for Julie Brown, who helped pull this all together from Sherry Poe Bernard's textbook, which we use for our risk adjustment course. So thank you, Sherry, for pulling out the case studies and doing all that background work. Bye, guys.
Do you need more medical certification and business training? Learn more at www.cco.us.